Welcome to our LabCoP session for June 2020. And it's a pleasure to have you today. My name is Anafi Mataka from ASLM. As usual, I'm delighted to be your session moderator today. The COVID-19 pandemic has impacted our lives, the whole world. It affected us in many spheres, social, mental, as well as physical aspects of our lives. Health services have been hardest hit, we could argue, threatening the gains that have been made over the years. Today, we would like to be discussing differentiated service delivery for HIV, which has been defined as a client-centered approach, which aims at simplifying and adapting HIV services at to different groups of people who are living with HIV. To help us look at this important topic for DSD in the context of COVID-19, we are honored to have two well-respected practitioners to grace our session today. We have Dr. Peter Preko, who is the project director at ICAP CQUIN, which is an HIV learning network, just like the LabCoP, which focuses quite largely on differentiated service delivery. He will be joined by Dr. Have Kambale, who is the DSD coordinator in the Ministry of Health, Eswatini. Ladies and gentlemen, help me welcome Dr. Peter Preko and Dr. Have. Peter, over to you.
Thank you very much, Anafi, and thank you to ASLM for inviting CQUIN to be part of this important webinar. It's our pleasure to be here and to share some of the lessons we've seen from the CQUIN network during this COVID era. So my presentation is going to focus on DSD policy and practice adaptations in response to COVID-19. I'll start by giving a brief overview of what differentiated service delivery is, and then share with you the progress that countries have made in response to DSD implementation leading up to COVID-19, and then the adaptations that happened as a result of COVID-19, and then discuss some questions and challenges. So as the International AIDS Society defines, differentiated service delivery is a client-centered approach that simplifies and adapts HIV services to meet the preferences and expectations of people living with HIV. What you must note is that DSD is about the how of service delivery and not the what. So it involves dialing up or down the service intensity, service frequency, service location, and the service provider in order to meet the different preferences and expectations of people living with HIV who are receiving services. So the first question we want to ask is why differentiated service delivery? Most of you know about the 1990 targets by UNAIDS, which is now 95 for some countries. And what we can see from the UNAIDS chart, as I'm showing here, is the fact that we have made much progress in terms of achieving the 1990 targets. And for those of you who are aware, the expectation is that if we are able to achieve this target, we will reach epidemic control. So it is fair to say that we have made good progress towards achieving epidemic control. However, there is still a lot that needs to be done. We still have a lot of people that we need to test. We still have a lot more people that we need to put on treatment, and of course, for viral suppression. Again, if you look at the different people on treatment, they fall into different subpopulations and therefore have different needs. If you also look at the clinical categories of people on treatment, again, they fall into 4 main categories. We have those who just initiated treatment less than a year, who are doing well, or those who initiated but very sick with advanced disease. And we have those who have been on treatment for some time, more than a year, who are stable or who are failing treatment or are unstable. So we have these 4 different categories of people who need different services. And therefore, it is clear that one approach will not meet the needs of these different categories of people. And therefore, we say that one size does not fit all. So who is clinically stable? According to the WHO, this includes people who have been on treatment for more than a year with no adverse conditions, no current illness. They have a very good understanding of adherence and why they need to take their treatment and stay in care. And also there is evidence of treatment success, which is measured by 2 consecutive suppressed viral load, a rising CD4 count, or CD4 count greater than 200. I must mention that this criteria is changing in the context of COVID, and I'll share some of what is happening with you. So, in terms of stable recipients of care, there's now growing evidence that supports provision of less intensive DSD models to recipients of care. And when we talk about less intensive models, this include these 4 models that I have highlighted here, which fall into either individual group models in a facility, or group models in a facility, or individual models in a community, or group models in a facility. So if implemented well, we know that DSD has the potential to improve the quality of care, because if we are able to decongest the health facilities and we provide client-centered approach, then we'll be meeting the needs of each and every client. We'll be able to improve adherence, retention, and viral suppression. We'll also be able to reduce overcrowding at the health facilities and therefore enhance patient and provider satisfaction. But then we also know that we can improve efficiency in the health sector by delivering differentiated service delivery. And this will include focusing resources to help us focus resources on the most needy patients on care. So that if those who are stable, are on treatment, are coming to the facility less often, and the facilities are decongested, then providers, we believe, will be able to spend more time on patients who are unstable and need more attention. So by so doing, we'll be able to meet the different needs and be able to achieve the quality that is needed for every client. So now let's look at some of the implementation progress leading up to COVID-19. I'll start by introducing CQUIN Learning Network to those of you who may not be aware of this network. Similar to the LabCoP, it is funded by the Bill and Melinda Gates Foundation, but this network is led by ICAP at Columbia University. It's a platform of 14 countries currently. It's growing, so we'll be adding more countries. And it's used to share innovations, DSD-related innovations, best practices, and we have a very strong collaboration with the community of people living with HIV. One of the tools that this network uses is the CQUIN Dashboard. It helps countries to identify gaps in their implementation and be able to prioritize key interventions to be able to scale up DSD. It's a maturity-based model dashboard. So we have, it has about 13 domains, and we score each domain from red to dark green, where red is a domain where the country is at very early stage of implementation, and dark green is where you have achieved a very high level of implementation in this domain. So using this domain, countries have been staging themselves over the past 4 years of the CQUIN network. And as you can see, the top one is the dashboard 2018 for the countries that were part of the network at the time. And the bottom is 2019. And if you compare 2018 and 2019, you see more dark greens and you see less red. So you see countries have progressed, have made improvements in terms of scaling up. If you look at the columns towards the right, facility coverage, patient coverage, and you compare 2018 and 2019, you see that patient coverage is becoming more green for each of the countries. And that shows that a lot has been done and the countries were making good progress leading up to COVID. So now let's look at some of the changes that have been mandated in response to COVID. So some of the key considerations that countries had at the back of their minds as they were making these changes is to protect the healthcare workers and to protect recipients of care and the communities within which they live. But then also very importantly, to protect our programs and make sure that they remain resilient. So these were some of the conditions that, or the considerations that informed the changes that the countries made in response to COVID. And these changes fall into 4 main categories, which include relaxation of eligibility criteria for DSD in some countries, and some countries also provided longer multi-month dispensing. Some of them expanded and modified community-based DSD models, and then others deprioritized routine viral load monitoring. So my next 4 slides, I'm going to give you a little bit more details on these 4 changes. So looking at the relaxation of eligibility criteria, some of the main changes that the countries made include the fact that viral suppression was no longer a requirement to be on differentiated service delivery model for less intensive, to be on less intensive DSD model. And therefore, newly initiated patients on ART were able to start receiving multi-month dispensing in some of the countries. Patients with unsuppressed viral load also continue to get multi-month dispensing while receiving remote adherence counseling. And in some countries, even patients with advanced HIV disease were allowed to get multi-month dispensing. Interestingly also, some countries started giving multi-month dispensing to children, pregnant, and breastfeeding women. These are subpopulations where, although WHO had given the guidance that they could receive multi-month dispensing, countries were feeling reluctant to do so. But COVID more or less enabled this change to happen, and to happen very rapidly. With respect to provision of longer multi-month dispensing, some of the examples that countries adopted, including moving to 6 multi-month dispensing. 6 multi-month dispensing was something that some countries had started discussing. PEPFAR had recommended it and was pushing for it, but COVID enabled it to happen very quickly for some countries that were sure of their supply chain and they thought they had enough drugs to be able to do so. Some countries that were just beginning DSD were able to rapidly adapt 3 multi-month dispensing and in a phased approach. And then also some countries that were previously giving monthly refills to community ART groups quickly moved to giving them 3 multi-month, or in an attempt to reduce frequency of visits to the facility in order to protect both clients and service providers. So this is just an example of what happened in Mozambique, looking at their 3 multi-month dispensing. If you look at the chart on the left, up to March, the defaulter rate was more or less stable at 8%, but then it jumped quickly to 10% when the COVID restrictions started, or people became afraid of even going to the facility because Mozambique didn't really lock down. But then they responded by scaling up multi-month dispensing, making sure that more people were enrolled into multi-month, relaxing their restrictions to facilities that are able to provide multi-month. And as you can see, between March and May, the proportion of recipients of care on ART who were given multi-month, 3 multi-month dispensing increased to almost 60%. And with that, a reduction in the defaulter rate back to baseline. And then countries also made changes to their communities-based models. Countries expanded these community-based models to include home-based delivery, which was very interesting because most countries were not doing home-based delivery beyond the pilot level. And this became like a policy for some countries. The elderly and people with pre-existing conditions that we know are at risk of COVID were prioritized and provided with home-based delivery of ART. And then for some countries, group-based models were disbanded, or as for example, like the teen clubs, or their meetings were suspended and they were only allowed to meet for refills. For the purpose of this LabCoP, I think you'll be interested also in seeing that viral load monitoring was deprioritized by some countries. And so, as I mentioned earlier, some people were receiving or are receiving 3 multi-month dispensing, although they are unstable or they're not virally suppressed. So if you are not monitoring their viral load and they are receiving 3 multi-month dispensing, we are not sure what is going to happen to them. So these are some of the challenges that we are thinking about. But some countries have moved to targeted viral load for recipients of care when they suspect that they are failing. But the routine monitoring for some countries have been deprioritized. And this chart, I took it from WHO. It's a survey that they did to look at how service disruption happened in response to COVID. And they realized that, as you can see from the top, viral load monitoring is one of the services that has been mostly affected during this COVID era across countries. And just looking at one project in Kenya, I'm afraid to mention the name, Afia Pani project, I think. You see up to month, they seem to be scaling up viral load uptake. But then from March, when this COVID came, you can see a sudden drop in uptake of viral load. Now, Kenya didn't really deprioritize viral load, but this is basically a response to recipients of care inability to probably go to facilities because they are protecting themselves from COVID, or spending less time in the facilities when they go for their drugs. So that resulted in this picture that we see here. So to end, just to discuss some of the challenges and the key questions, we are not sure, how long COVID is going to last, but then the main question is whether these changes, some of these changes are very good changes, and we are not sure whether they will be sustained beyond COVID-19. So this is something that we need to keep our eyes on and keep monitoring what happens to that. Countries have concern about ARV supply interruptions. Most of you know some of these things come from India, China, and with the travel restrictions and limited flights, etc. Countries have concerns. In fact, some countries have started rationing like second line drugs, for example, which they have very low supplies of. We've also seen the challenge with M&E in this era. Services have been disrupted. People are picking drugs from facilities that are closer to them, not where they have been registered and they were receiving their services for some time. So the main challenge is how to make sure that all this data, especially from the community level, can be collected and entered into the main system in order to make sure that we don't have artificial loss to follow up. But some countries have started responding to that, and a good one is Uganda, that have created a makeshift register to collect and harmonize this data. I think I asked the question about the viral load, routine viral load that has been suspended. What will be the impact, especially to those who probably may be failing treatment and we will not know, so that we can switch them to a more effective therapy. And I'm sure some of you are wondering whether it is possible to continue to provide antiretroviral services and routine viral load monitoring while protecting people from COVID. And I think that's a discussion that we can have. How can we effectively provide routine viral load monitoring even in this era? And what about diagnostic services for people with advanced HIV disease? I'm not sure what is happening, and maybe this is something that we can discuss beyond just the routine viral load monitoring. So I want to thank you very much for your attention, and I'll take questions when happy to discuss this during the question and answer time. Thank you.
Thank you very much, Peter, for the wonderful presentation. Colleagues, I'll ask you to hold on to your questions. Please keep them coming into the comments or chat box whilst we move on to the next presentation from the Ministry of Health, Eswatini, by Dr. Have Kambale. Have, over to you.
Thank you, Anavi. I'm trying to share my screen. Okay, thank you for the opportunity to present. I'm going to take you through the Eswatini specific DSD and HIV policy change made in response to the COVID-19 to protect both healthcare workers and recipients of care in our facilities. So this is the outline of my presentation. So I'm going to take you through quickly to all these points. So it has to be noted that on the 17th of March 2020, so His Majesty the King Mswati III declared COVID-19 as a public health emergency in the Kingdom of Eswatini. And a full lockdown with checkpoint and police enforcement were implemented, where only essential workers were allowed to operate and to go to work. So this except some business, like including water and electricity suppliers. So after the COVID-19 have been declared as a public health emergency, so the National Disaster Management Agency has become responsible for the overall coordination of the COVID-19 response. So, and then during the lockdown due to COVID-19, so we had two impacts. So I'm highlighting on my left, we had like as a negative impact. So clients were missing their appointment because there were no transport available to go to the health facilities. And there were also an intentional disclosure of HIV status at police checkpoint because they had to prove why they were on the road going to the facility. They had to produce their health cards. There were also disruption of the supply chain resulting to limited stock of commodity, including HIV, ARVs, and also limited access to viral load because most of the clients were seen in the community. And then also, as Peter mentioned, we also suspended all group models who were happening in the facility. This included teen club and treatment club, and in the community, we suspended the community ART groups, which were limited to drug distribution. So this has as a consequence of the reduction of some of the benefits of the group model, which includes adherence and psychosocial support. So generally, there were a risk of losing successes and gains achieved before the COVID-19 period. So as a positive impact of COVID-19, so after the COVID-19 have been declared as public health emergency, so the response was included all the ministries. So we were implementing multi-sectoral response, and we are happy to see that now other ministries are also engaged in the decision-making about health-related issues. And also the country were able to implement a new DSD model to try to respond to specific clients' needs during this period. And multi-month refill models have been taken to scale because we wanted as much as possible to keep our clients away from the health facilities. And then also we integrated most of the health services into HIV services. And this includes TPT, NCDs, family planning, and other services. And also in most of the facilities where the wellness unit was dying, so this unit have been revived so that healthcare workers can be screened, and the result of the screening were filled in their specific files. So just to remind the audience about our national enrollment of DSD. So as Peter mentioned, some different DSD models. So as of December 2019, we had 60,000 clients who were enrolled in DSD, and the majority of them, 75%, were enrolled in fast track, followed by 9% enrolled in teen clubs. Then we have 6% of clients were enrolled in family-centered care model, and 5% of clients were receiving services in the community through their community active groups. And as you can note in this enrollment statistic, you can see that clients who were enrolled in 6 months refill were only 267 at that time. So also as a reminder of our COVID-19 updates, so as of June 23rd, we had 674 confirmed cases in the country, and we had 348 active cases. So among the active cases, we had 7 deaths. So this is, as you can see, the numbers are increasing, as well as the total number of recoveries are also following increasing. So what were the rationale of implementing changes? So we wanted to reduce the risk from traveling to health facilities. We wanted to have recipients of care to receive their services at home to avoid them to board public health transport, which has a risk of contracting COVID-19. And also we wanted to reduce patient volume at health facility. We want as much as possible to decongest health facilities. So this has a result to reduce the risk of community transmission in the health facilities. And also we wanted to provide community services by taking in considerations community level activities. So we are also, as I mentioned, integrating all the services, and they are provided in the community, and taking in consideration stigma related to HIV services. So in overall, all the changes were aimed to reduce COVID-19 exposure for people at higher risk. This, as Peter mentioned, patients who are aged more than 65, patients with high viral loads, patients with tuberculosis, and patients with NCDs. So what were the key policy changed? We also relaxed some of the eligibility criteria to our DSD models, because initially we were considering a client as eligible if a client were on ARVs for more than 12 months, with 2 consecutive undetectable viral loads, no opportunistic infection, and good history of adherence. So during this period, we provided community services to all the clients so that they are not forced to come to a facility for services. And this included ARVs, TPT, TB, and NCDs. And also, as I mentioned, we scaled up multiple month refill. So this included clients who were initiated on ARV, they were receiving a 3-month refill. Clients who were already on TLE and TLE were receiving 6-month refill. Children and adolescents were also receiving 3-month refill, because initially, before the COVID-19 era, they were only receiving 1 or 2-month refill. And also clients with second line were also receiving a 3-month refill. And also for TPT, NCDs, and other services, they were receiving 2 or 3-month refill according to the availability of different drugs in the facilities. So what is our viral load sample collection experience? Because as I mentioned, all the services are provided in the community. So what is happening is that implementing partners are supporting facilities with vehicles to take service in the community. And because of the limitation of the number of people in one vehicle, so it was only a strict limited team which are going to the community. This excluded this excluded some of the services, including the viral load collection. So, but now later on, because we wanted to protect gain and achievement which we have before the COVID-19 area, so we prioritized clients on second line, clients with detectable viral loads, clients with who were coming for the first time after initiation, and clients with poor adherence to collect viral load. And this was done through either full blood or DBS collection as shown in the pictures. So, and then after that, because of the need of protecting the gains, additional staff and logistics have been made available to collect sample in the community. And so far we have observed that the viral suppression has been maintained beyond 75. So as illustration, I'm showing these graphs with the viral load coverage, national viral load coverage. As you can see, our average is beyond 16,000, as it was in January, February, and March. And then from April, we have seen a decrease because of COVID-19. We reached 10,000 clients who collected viral loads. And as you can see, because of the implementations of the increase of the logistic to make sure that viral load is collected in the community, you can see that the numbers is currently going up to 16,000 as before the COVID-19 era. And as you can observe, the viral suppression rate is maintained beyond 95%. And for the multiple month refill, if you remember my previous slide, we had only, in December, we had only 267 clients who were enrolled in 6-month refill. But with COVID-19, as I mentioned, it was a positive, has a positive impact to scale up 6-month refill. Currently, we had 22,631 clients enrolled in 6-month refill. This includes 19,000 clients receiving TLD, 3,500 clients receiving TLE, and we have 25 clients who are receiving other regimen, which are either first or second line. And this map of the country is showing us that how the different community distribution points are scattered across the countries. And so far we have 69 facilities in total which are implementing community drug distribution. And so far we have 355 community distribution points scattered across the countries. But our plan is to have in total 619 community distribution points across the countries. So what are the lessons learned? A key lessons learned while implementing community commodity distribution and the multiple months refill is that our facilities have been really decongested. So these two pictures is showing us a waiting area at the ART units in 2 of our high volume facilities at the peak time. And as you can see, we have actually no clients on the waiting area because most of the clients are receiving their services in the community. And the model, community distribution, model as an initiative to be sustained beyond COVID-19 era. And the fosters have been actively followed up and reviewed in the community at our facilities. And the majority of clients are excited about the model. That is why we decided to make sure that these models continue beyond COVID-19 periods. And engagement of clients on their preferred points of refill is important because we have realized that if you are not providing services where they want to receive it, most of them were defaulting treatment. And different channels have been used to communicate with clients, to set up appointment dates and communicate with clients who miss their appointments. And this includes telephones, rural health motivators, and expert clients. So initially, when we started implementing the model, we had challenge of managing data collected in the community because we're using paper-based forms. But currently, our M&E office is working on a CMIS Lite version so that the version can be installed in tablets, which allow the collection of data in the community. And then a strategy to reduce stigma. So most of the partners are using unbranded vehicle. And also we are conducting our recruitment through existing ART support groups. And we are integrating other services, not only providing HIV services. So what are our country's priority questions? So we want to know the effect of the country's lockdown due to COVID-19 on recipient of care's adherence to ART. We want also to know the effects of the new model of care on viral load coverage and suppression rate. We want to know the trends of missed appointment during COVID-19 period and the effect of the global lockdown due to COVID-19 on the country's supply chain, because we are experiencing stock out of some of the commodities. And finally, we want to assess if the outcome after COVID management is different among people who are on ART and those who are not on ARVs. I think that was my last slides. I will be happy to have your question. Thank you.
Thank you very much, Hervé, for the presentation. Colleagues, it's now time for questions and answers. So we shall be taking questions from the chat box as they come through. I'll take the first few questions. So keep them coming as they come through. We'll be taking them as they are there. We also acknowledge that there are quite a number of questions with regards to downloading certificates. We'll address that at the end of the session. Let me take this question from John Mapulanga. John says, for viral load monitoring, I am suggesting the use of viral load POC, which takes monitoring as closer to the patient as possible. Currently, we have some true POC, which are WHO PQ'd in use. It's more of a comment. I don't know, Peter and Hervé, you want to build on that one? Sure.
Well, I think it's a great comment, and the easier we can make it on our recipients of care, I mean, the better. I think if we have a viral load point of care, it makes it easier to collect the sample, makes it easier for the facility to even get the results. And I mean, you don't have to send the client to another place to collect samples. So as these additional tools become available, if we can increase their utilization to the benefit of the client, I think that would be great.
Thank you very much, Peter. Mlingazi Mango says, how best can we leverage telehealth or telemedicine or e-health in Africa as a way to improve HIV interventions from testing to ART?
I think if there is one thing that COVID is teaching us is to innovate and to think outside the box. We have not utilized telehealth or telemedicine as much as we probably could. Everybody prefers to come to the facility. Everybody prefers to come and see and talk to a doctor. And even as we started scaling up DSD, I mean, that was some of the challenges where Either the provider is resistant to let go of the client, or the client is resistant to spend less time at the facility, and so, these are areas that I think we can continue to explore. And I think in the developed countries with COVID, they are doing a lot of that now. They are doing online consultations and prescribing treatments and emailing it to people so that you don't have to go to the health facility. I think as much as possible, like one of the concerns that providers have for, let's say, 6 multi-month dispensing is that, okay, this patient is going away for a very long time. How can I be sure that he's still or she's still doing well? And I think we can use telemedicine to support that. Now we have WhatsApp, we have other platforms. You can easily call the patient and find out how they are doing. If you have a concern that going away for 6 months is too long. I know that some countries have started using virtual adherence counseling for recipients of care who are initiating treatment and we're giving 3 multi-month dispensing, or who have unsuppressed viral load and still we're giving 3 multi-month because they want to minimize their engagement with the facility. And so they continue the support through telemedicine. And so I think that is an opportunity that we can explore.
Okay. Thank you very much.
In addition to that, I want to share the Eswatini experience, because with the support from ICAP and Resolve to Save Life initiative, so we have been able to introduce a virtual platform for trainings of healthcare workers and for our routine meetings. And also we are going to start soon using telemedicine for our clients who are admitted in COVID-19 centers, so that healthcare workers who are working in COVID-19 centers can be able to discuss cases with specialists which are in other facilities. I think it is a good question and good opportunity for us to extend that, to use it for consultations. Thank you.
Indeed. Whilst you are there, Heavy, there is also, I think, a comment from Lucy, and she says she's just wondering whether you have also tried to monitor the impact on TB services as well. Yes, we are closely working with the TB unit, and as I mentioned, we have been able to integrate all the services, include the TB management. So we are closely working with the TB program to make sure that services are integrated and all clients are receiving services in the community. This includes also TB services. Yeah, thank you very much. Coming back to that point which was raised around viral load and the ability to get a result, there are also other modalities to get the same viral load. So there is a comment and within the chat, which I think is also very important, talking about DBS. And this is from Mo Mungati. He says he thinks DBS is a great idea, but it needs to be introduced with other innovations that improve TAT of results. So their experience shows that DBS has reduced their numbers in need for viral load testing, but we have also suffered from very long TAT. So he says, from a clinician perspective who needs a result early, it becomes frustrating. Use of LIS might reduce TAT though, but not by a lot, but still needs to help. So I think he's mixing the issues of innovations, telemedicine in there as well. All right. I think we also
just to mention quickly about this, and that is a very good point that I think Mungati is raising. And I think one of the main reasons with the long turnaround time has to do with, when we are using DBS, people tend to budget, because it's a sample that you can keep it on the shelf for a very long time before it goes to the lab. And so sometimes you find out that these samples stay at the facility for a very long time before they are picked up. And I think if we can find a way of minimizing that, how long the facility stays, the samples, stays at the facility before they're collected. I think that will help reduce the turnaround time. But definitely the idea of, using LIS to support that, to reduce the turnaround is a good idea. I know that South Africa has a platform called Itemba, where the samples, and I think Eswatini, I don't know, Kambali, if you want to talk about it, I know they had planned to pilot it in Eswatini as well, where the samples, the results, valid result is returned to the provider as well as to the recipient of care, so that even if the providers receive it and don't act on it, the recipient of care will have it and will be able to get in touch with the provider.
Yeah, it's a very important point indeed, Peter. We also had colleagues from Itemba here in the March session, if I remember well, really explaining that. And I think it's one of those key breakthrough technologies that we could actually build on, particularly in this context. I want us to move on with the questions, and I'll combine two questions which are similar here, one from Lucy again and from Charity Mukoi. Charity says, what's the impact of integrating other services such as TB, family planning, apart from ART in these COVID times? And Lucy says, are there any plans to expand DSD beyond HIV? I know there are talks around DSD 2.0. So she says one thing that COVID has taught us is the importance of integrating HIV services.
Okay, thank you, Molusi and Charity. So I think for us, integrating the services was initially mainly to reduce stigma. Because when services are provided in the community, if services is known to be only HIV services, so recipients of care were not coming to receive services because of stigma. That is why the idea came to integrate other services, and it made a positive impact because most of the recipient of care who was in chronic care, they couldn't come to the facility, they were defaulting, being for NCDs on TB treatment. That it was easy and important for us to integrate services so that we are not disrupting the services of of ARVs and other services. So for us, initially it was because of stigma, but later on we felt that it was important to maintain that activity beyond COVID-19. And DSD, not only for HIV services, so this is something also we have been sharing with other colleagues in the countries. And also I have to mention that we have a few DSD models which are integrating NCDs into DSD. We have clubs for clients with HIV and NCDs, so they're receiving their treatment at the same time. And also we are working with the TB HIV units to integrate TPT into DSD as well. So for us, integration has been really a good initiative, and it has really helped us to strengthen the health system in general. Thank you.
Thank you, Harvey. Talking about innovations again, and also one of the reasons why we have this session today is really all about maintaining the gains that we have made so far. And John here says he suggests the introduction of ATMs for dispensing. He said it's for dispensing AIDS drugs in various areas. What are your thoughts?
So thank you, John, for the question. I know that this is one of the models implemented in South Africa. But for us, as you saw in the graph I showed for the DSD model, we have many DSD models. And for us, so far, it is working for us to reach and to respond to the need of clients. So it is one of the models we thought of implementing in Eswatini, but so far we haven't have enough logistics to start implementing that model. It is a good initiative, but for us also, the other models have been working for us well in the country.
Thank you.
I think it's definitely, an initiative that may benefit people in urban settings.
Mm-hmm.
And I know other countries are exploring that. I know Kenya in November did a south-to-south visit to South Africa to see, to observe those ATMs. So it's something that other countries have interest in, and it will definitely benefit people in urban settings. And Kambale, I don't know, there is this filling station in on the way in Eswatini, on the way to Gables, where they have a kind of ATM-like medicine dispensing within in the shop. So you can go in there and pick your over-the-counter drugs without having to talk to anybody. Or just like a vending machine. It's similar to a vending machine, actually. So you can pick your drugs, you can pick condoms just through the vending machine, and so that it's something that can be built on.
Yeah, interesting indeed. Thanks, Peter. As we move on, Kambale, you mentioned earlier on something around stigma, and you mentioned the use of non-branded vehicles. How much of it is it a barrier when it comes to really implementing DSD, particularly in the context of COVID? And I would also be interested to know if there are any recipients of care within the audience today to also make a comment on that.
Okay, thank you for your question. So in Eswatini, we have key partners who are working in the HIV program. And I think the public knows them, and they know that most of, if there is an ICAP vehicle coming to the community providing care, they would know that maybe it is like they're bringing HIV services in the community. And we realized that during the COVID-19, because we wanted to scale up community commodity distributions, that you find that you made an appointment with clients, but when actually the team arrived in the community, those clients were not seen in the community. And some were like calling, asking like the team to move on to go to another area where the person will find them. And later on, when we conducted a quick assessment to ask, especially clients who were defaulting treatments, they were saying that because you are bringing vehicles which are branded with partners providing HIV services, that is why we are not coming to receive services where you are stationed. And they've requested that if possible, if partners can use unbranded vehicle. So this was like a request from recipient of care. And most of the partners agreed and abide to that request. And this has reduced like stigma in the community. And in addition to that, as I mentioned, the integration of other services, not only HIV services, also contributed to reduce the stigma. Over. Thank you.
Thank you very much. Moving on to the Otieno, wants to know, is there any clue on the impact of ART on virulence of the COVID-19 disease? Also things like the trend of severe adverse events as a result of drugs administration. Anything along that lines?
So as I mentioned, so this is one of the questions we are trying to respond in Eswatini, because there were a publication in South Africa which shows like a different trend of COVID-19 among HIV positive clients. So we are also trying to collect data, and at one point we'll be able to analyze and see if there were like the outcome were different among clients who were HIV positive and those who were on ARVs, especially concerning the severity of the disease. So this is something we have in our minds and would like to explore, analyze, and share with other countries.
So just to add, I know that one study was published in the Lancet that described COVID among HIV, people living with HIV, and they didn't find any difference in terms of the severity among patients with HIV and the general population. I think these are people on antiretroviral therapy. So, I mean, once you are suppressed and you don't have any clinical symptoms, I think the disease progression for COVID is the same for people on ART compared to the general population.
Thank you, Peter. Thank you, Peter. As we move towards the end, I just want to go back to one of the recurring sort of themes in the question and chat. I would summarize it as really, I think, result delivery and ultimately affects result utilization. And there is a comment here from Luciana who mentioned that many LIS, these lab information systems, have the capacity to send test results automatically to the patient. But it is the capacity that needs to be unlocked by many of the IT experts. And I think this is a very important subject indeed, particularly in this subject. We touched areas of alternative sample types when it comes to viral load results, which have an impact, I think, for DSD, although Peter mentioned that at times, sometimes that may not be a requirement. I would also want to direct you to one of the guidances by WHO, which was launched around about this time last year during the IAS in Mexico. It's a molecular toolkit for alternative sample types for viral load. I think many of the issues that were being discussed in here on how to improve turnaround time are there as well. And then how we can then tailor make the possible samples to each and every environment. I also want to make a few quick comments on the questions that were coming, particularly regarding the certificates. I'm sure you have seen comments and responses in the chat box where the instructions have been put in the ASLM Academy webpage. But just as a summary, all you need to do is to be able to go into the ASLM Academy page, register if you have not registered. If you have registered, you will need to log in. And once you log in, you should be able to see a section which has the courses that are there. And for those that have attended this session, you should be able to go directly and click the button, download button, and then you should be able to get your certificate there. For those that would want to re-watch this, you will need to watch this session again, and somewhere along this session, this code will appear for you to be able to get the code for downloading the certificates. I think that addresses the question on certificates. As we are about to also close, we shared with you an email or a survey wanting to know what exactly is the impact of COVID-19 within your settings. Thanks for those that have already responded. There are a few countries that are yet to respond. Kindly respond by as soon as possible. We had given the date of the last date of responding to be tomorrow. So we are looking forward to receiving your responses as well. Dr. Have, in 30 seconds, I would like to ask you to just give a few remarks regarding today's discussion.
Okay, I would like to thank the ASLM team for inviting us to share our experience. And also I would like to request that all the countries, we put our effort together, we share our experiences so that we are able to work together and control COVID-19. I know that it is something we can do together, and we have to make sure that we are protecting the achievements we have before the COVID-19 era. So I think that will be my last remark. I'll thank you.
Thank you. Dr. Peter?
Just to thank ASLM and the participants for the opportunity to interact with you on this platform. And to mention, I saw somebody comment in the chat that DSD is the way to go. And just to emphasize that indeed, DSD is the future, and we should all make use of our various platforms and opportunities to support it. Thank you very much.
Thank you, Peter. And I also want to echo your words. Indeed, DSD is the way to go. Integrating services is the way to go. And we look forward to DSD 2.0 as we move on. Ladies and gentlemen, it's been a pleasure once again to have this lively session with you. We will be announcing very soon our next session. Most likely it's going to be next Thursday. So stay tuned until we meet again.